So, dear colleagues, the plenary session is over, and we can start our roundtable on oncoscreening. And the topic of our session is oncoscreen. Is it worth it? And my name is Igor Khatькov. I will be the moderator. I am the chief specialist for oncology, and we have all of our speakers here at the stage. We will make the introductions before their presentations so that we will cover the most important topics. We won't waste time on that. And Sergei Morozov will join us shortly. And we started our conference at the oncology stand with the two big devices, and we asked people who were passing by to drop a ball, whether they are for oncological screen or they are against it, and it's half empty, one of them. If we calculate all of the balls, it's 1,200, and these are the people who voted for the oncoscreen favor. And people who had doubts, there we had only 50 votes. A screen is a very serious issue, and we are used to talking very often that. And cancer is better treated at the earliest stage. And the successes that we have can prolong life, and prolong life with good quality of life, and sometimes we decrease the mortality, and early diagnostics is the foundation, which is mainly based on screening. There are lots of specific scientific topics our speakers will cover today, and we are used to that, and that public voting describes that when you're 20, you need to go for cervical cancer and then colonoscopy, and if you smoke for 10 years, if you don't smoke for another 10 years, CT of lung with a low dosage of radiation. Whether it's necessary, depending on development of the country, region, depending on level of alcohol consumption. And our first speaker is a professor from Tokyo, and he has no relation to screening, but nevertheless we believe that his presentation will be of interest. This is a Nobel Prize winner for studying autophagy mechanism, and these mechanisms may have theoretically a major impact that can be called like cell technologies. He will speak about the role of what we call fundamental studies in medicine, how they influence development of medicine in general, and also in its clinical part and in terms of management as well, because screening is a scientifically proven test. And there should be scientific approaches to the use of screening methods, and our speakers will cover that topic. And Mr. Yasunori Asumi, to whom I would like to give a floor, he will speak about basic sciences in development of medicine. You have the floor.
Okay, thank you. My name is Yoshinori Osumi from Japan. It's a great pleasure for me to be here as a speaker of this wonderful table discussion session. However, I'm not a medical doctor. I'm not working on the cancer therapy. So probably I want to discuss about the basic biology to the medical application as an example of my 30 years of work in autophagy. Okay. as you know, life is just maintained by equilibrium between synthesis and degradation protein. And so recycling is so essential for life. But so degradation is very important, as just like a synthesis in our life. So just now, I briefly mentioned about how I launched into the autophagy field in using yeast. I didn't expect that will relate it to cancer research later, but that's the way basic science starts. Okay, I interested in the yeast vacuole because not so many people interested in the yeast vacuole at that time. So I want to know what's the function of a large compartment in the cell. This is a picture of yeast vacuole, and I expected that is acidified by V-type ATPase, and that contains various kinds of hydrolytic enzymes in it. So I expected that will function just like a lysosome in our body. The starting point of my, this is a movie, but it doesn't work. Yeah, this figure is just starting point of my work. If I put the vacuole protein is deficient mutant cell to nitrogen starvation condition, you can see right side movie that spherical body is just moving around in the vacuole. I'm sorry, I can't show that. This observation is exactly the starting point of my work. We are still working how and why these kind of phenomena occur in the cell. Okay. By electron microscopy, we found under starvation condition, suddenly this kind of membrane structure appear in the upper portion of the cytosol, and form
Можно помочь, чтобы вы переключались слайды?
Wow. Oh, sorry. Okay. Okay. This movie showed their form a double membrane structure. Those double membrane structure fused with the vacuole, and you can see spherical bodies accumulated in the vacuole as shown here. So I draw this kind of process in the yeast autophagy. If a cell faced nitrogen starvation condition, suddenly this kind of membrane dynamics appear, and a portion of cytoplasm is taken up to the lytic compartment by this process. So we started from this phenomena. We started the genetic screening of their autophagy defect mutant, and we fortunately isolated 18 ATG genes. Those are essential for yeast autophagy. Those genes are required for the membrane dynamics as shown in the previous slide. And within 10 years, we found those ATG genes are essential for the membrane formation and subdivided into these 6 functional groups shown here. I don't want to go in detail. But those kind of identification of ATG genes were very important for further autophagy research. And we found those ATG genes start accumulating the point of the vacuole membrane and form those kind of membrane structures. And we also revealed the 3-dimensional structure of ATG genes, protein. That is also very important. These days, structure biology showed their function so easily. So we are trying to we determined many ATG gene protein as shown here. And we recently found, as you know, many cytoplasmic protein showed their uneven distribution in the site, so that form a liquid phase separation shown here. The first reaction is forming this kind of a structure within cell. And we had 18 AT genes unknown function. All 8 those genes are unknown function. Finally, recently we found ATG2 has a quite unique structure, and we solved those kind of structure. Those protein is very important to deliver lipid to the membrane. So is autophagy present stage, it took for us 30 years, but we found those ATG protein very essential for autophagy. And also, but we are still quite fundamental problem to be solved. We don't have a quite quantitative assay of autophagy in the East, and we need many induction condition, degradation, and how it's related metabolic control. And when we got ATG genes, it changed landscape of autophagy study in mammals. We can see if I use one of the ATG genes as a tool, we can easily visualize the autophagy process as you shown here. And also, once we got the ATG genes, we can easily manipulate those genes. For example, one of the first example is ATG5 knockout mice die within 12 hours after birth. And also, all over the world, many people start working on autophagy in mammalian cell. And we found ATG genes are required for if we block the ATG gene in liver-specific knockout mouse, tumor occurs in liver. And so that means autophagy is so closely related to tumor suppression. And if we specifically knock out in brain, we have the neurodegenerative diseases in the brain by accumulation of those kind of farm materials in the brain. So autophagy related so many things. And so now we know autophagy has 2 major functions. One is nutrient recycling and also elimination of excessive or harmful material from the cell. And this slide showed the autophagy research paper appeared. When I started 1988, only 20 papers appeared. But now we have more than 10,000 papers appeared in autophagy. So this kind of burst of the autophagy research, mainly one reason is autophagy is related so many diseases problem. And as I said, autophagy is related in so many kind of the physiological events. One is a tumor suppression, and one is many early embryogenesis and starvation adaptation. And this slide shows the autophagy related to human disease. And we know the Perkin responsible genes for Parkinson's disease, and many diseases now appear to their autophagy. And this is one example, Parkin-related to the mitophagy that is related to neurodegeneration. And also, now overall the world, many people are trying to clinical trial for cancer therapy and autophagy inhibition. And also, many people working on the neurodegenerative disease treatment as autophagy. So I want to emphasize that my work on autophagy it took 30 years to solve many basic questions. But, and also even in the East, we are still quite early stage of autophagy work. But those kind of basic research are so important to understand the basic problem of the many diseases, including cancer. And that kind of the long-term experiment was have helped so many advance on technology. Thank you for the attention.
Уважаемый профессор, спасибо большое.
So, dear professor, thank you very much for your lecture. And I think we will take 2 short questions so that we have more time for discussions later on. Very short questions. Do you have any questions to our professor? And I would like to ask you, in your presentation on one of the uses of autophagy in oncology was tumor suppression. And you've been doing that for 31 years, this type of research. You've been studying autophagy. What do you think? How long will it take for these mechanisms to be used in clinical practice of cancer treatment, maybe in prevention or treatment of cancer diseases? How long it will take for us to use your scientific evidence?
Will be needed for implementation of these methods in clinical practice?
Yeah.
If it is possible, especially in tumor suppression.
Okay. The problem for autophagy is certainly related to the cancer, but as you know, cancer has various cell types, and sometimes so we need more careful analysis of or good model system to work on the autophagy deficient, autophagy related phenotype in the cancer cell. But still we need more careful analysis of what is a good phenotype or a good marker for autophagy deficiency in cancer cell. So actually we're trying to how we can measure the autophagic activity in each cell or mammary cell. That is very important, still quite important stage for us.
Thank you.
So, I think those who are interested in that, I think this is interesting, for fundamental medicine is the basis of our development. And Professor Yasunori Asumi will make 1 hour lecture about the topic that he was awarded Nobel Prize for, and I think that's great to listen to that. And we are moving on to discussion of our clinical and practical questions on oncoscreening. And I would like to say that mainly oncologists and healthcare managers are in charge of oncology screening. And I would like to give floor to Sergei Morozov, who is one of the leaders in treatment and in diagnostics of cancer diseases and radiology diagnostics as well. And he has a practical experience in oncological projects. We have a screening project together, and he will speak about it himself. I think he's a very efficient and proactive person. That would be very interesting to hear his opinions, and he will cover the situation in Moscow of the past years. So, dear Igor, dear colleagues, thank you for the invitation. Great forum. A very interesting topic indeed. I think the lecture of our Japanese colleague reminded us that nothing is eternal. Everything is developing. Diagnostics and medicine are developing. The methods are being changed. What may seem as standard today may turn out to be obsolete tomorrow. What do we have today? People from Moscow, Russian citizens, they make a check-up with the help of mammography. Whether it's correct? No, because mammography, that's a wide coverage, maximum accessibility. But we are losing the importance of very accurate, personalized diagnostics, which is mammography. Today, mammography. Tomorrow, it can be ultrasound, transmission 3D, diagnostics of breasts, and then MRI is a screen method. So everything is evolving. What was proven in international practice that mammography decreases mortality. In Russia, there is no screening. There are pilot projects, such as the project in Moscow, when specialized tests are done under control only for the risk groups. If the screens is organized in the right way, in 6-8 women, we make early diagnostics of cancer, say 6-8 out of 1,000 at first stage, which can be cured and which impact mortality. If the screen is organized in the right way, we have 1/3 less death from breast cancer. 1 out of 3 women do not die from cancer, breast cancer. To find one breast cancer, it requires about 150 tests. You know about X-ray of lungs. For one case of tuberculosis, you need to make 3,000 X-ray tests, and that's a huge flow of patients, and you may really miss something, and that's one of the massive programs. In mammography, each case is found after 150 tests, and very often we have discussions with oncologists, and there are lots of publications saying that screening is inefficient, and they quote US data but not have a systemic program of screening. It does not exist. The screening like they understand it in Sweden or Netherlands, that's a different story. In the Netherlands, they have data proving that there is a decrease of mortality from breast cancer by 34%. Out of them, 17% due to modern treatment like target chemotherapy and chemotherapy, and the other 17% decrease of mortality is thanks to a screening for early diagnostics of cancer. The screening should be organized in the right way. When patient attends doctor, visits the doctor's early diagnostic, about 1 million tests are done every year in Moscow, and there is a program of a replacement of analogous mammography devices by the digital ones. About 100 50 digital devices will be installed in local clinics. All of the studies will be uploaded to electronic medical management system. It's accessible to both patients and doctors, what Mrs. Rakova mentioned today. According to national data, the patient can be cured at the first and second stage with the highest efficiency. To cure him, it means the patient won't have the cancer. It's not just will be torturing the person or helping somehow. And then according to our Russian OncoWeb, so the first and second stage is curable. At the later stages, we also have some great achievements. An international program in Holland, the decrease in mortality for cervical cancer, breast cancer, colorectal cancer. So we add data to this table on the lung cancer as well, and it's also international experience, and they are decreasing the mortality with a low dosage CT, and this is the method which is accessible in Moscow as well. There are 2 pilots. I will not go into details. In case of lung cancer, these are risk patients without symptoms over 50 years of age, which are smokers or used to be smokers before. These patients need to undergo a low dosage CT scan and then biopsy with the CT control or transbronchial for bronchoscopy, histochemistry, and PET-CT, MRI, and treatment at early stage. And we provide for monitoring of the quality of diagnostics. We decrease the percentage of bad quality of diagnostics. We improve the quality of work of the doctors. And screening is not like the doctors work by themselves and do diagnostics. This is a powerful systematic tool which should be properly and carefully used. If it's organized in the wrong way, oncologists say that it's better not to use it because it can just confuse you. If you are interested in the numbers, we have such information. According to a Moscow lung cancer project, first stage diagnostics increased from 15% to almost 60%. Of course, this is a huge breakthrough. We diagnosticated at the earliest stage, and lung cancer is killer number 1. And there are more deaths from lung cancer compared to all of the wars in human history. It is a major contributor of cancer deaths. And correct me if I am wrong. And there is economic effect as well.
Talking about the costs on the patient treatment, we see that screening, it's not a one-year program. It should run 5 to 10 years, then it will be fulfilled, and certainly the growth of the gross product that is measured with the support of informational systems. Here we see calculations and planning to scale up screen program at large regions like the city of Moscow with a higher number of equipments and a number of evaluations or checkups that will allow to cover all the citizens. Talking about the breast check evaluations, there is a pilot program. We are talking about digital mammographs. How to understand whether it's a good or bad clinic? It should have modern equipment that allows to compare results digitally, previous and next results. It should be linked to your system. And Anastasia Vladimirovna has mentioned that even PET-CT tools are also connected to electronic system, and all doctors will have data on each patient and its personal account, so that the patient doesn't have to bring lots of discs and papers that lead to a waste of time, both of patient and doctor. Personnel should be qualified in order to perform the screening. They should undergo a training. We use a PGMI system that ensures a high quality of screen, then mapping of the core biopsy, with the right verification of the diagnosis, and that provides all opportunities to provide right treatment. Screening works when it's carried out at two stages. When a woman with a primary diagnostics goes to a specialized center that specializes at breast cancer treatment. There are a number of centers in Moscow, and there are more and more centers are being opened, like Diagnostic Center number 1, Oncological Hospital 62, Hospital 57, and the Clinic of Female Health. There are more and more centers that specialize on the treatment of breast cancer that have. Talking about screening of the breast cancer, we see a higher growth of a tumor from to up to 56%. That were detected at early stage. There are false positive results. It's a big issue, but it's linked to underqualification of personnel. Sometimes doctor is afraid to indicate that mammography shows enormous, most complicated diagnosis in medicine is to say that everything is okay. What if somebody is going to check my results? It's better for me, to stay on the safe side and to write something more complicated, but to make sure that I'm not making a mistake. So it is a big issue that have to be solved out as well. Sometimes doctors do not know terminology like Biorex that is not used mandatory in Russia. In Moscow, there are recommendations to use this terminology. In other words, training is the key to success. There are quite good, successful examples in other regions, including webinar trainings done by our center and the center of Loginov. Thank you very much for your attention. Thank you very much, Sergey. As we agreed, you can ask 2 questions. Speakers certainly have questions. Okay, if somebody have a... David, I think you wanted to ask a question. Thank you very much for such an interesting report. I have a practical question. Does it mean the amount or value of qualification when you do a screening in order to make a decision for the further evaluation of the patient? Thank you very much for this question. Certainly, the goal is to find the tumor less than 1 centimeter. And the most Nelson trial showed that it's not enough to make just shots. The goal is to find tumors less than 1 centimeter. Yes, I was talking certainly about the volume or the size of the tumor. Do you track detected cases? Do you track what's going on with the detected cases, what's going on with the patients? Certainly, through cancer register, through oncologists, we we track what's going on. We even call back to the patients in order to understand what really happened, what kind of evaluations they underwent later. And we see that there is a decrease of 1 year mortality. So we want to track those results, but even personally we get in touch with the patients. I think there are lots of, we raised lots of questions that could be subject to discussions, but we can discuss them a bit later because unfortunately we are limited in time. So I have another question, if there is there is also question from the audience. Let's listen to it first. Well, you talked a lot about mammography, and as we see in European countries, mammography shows, and we are talking about quite many observations that mammography shows the most frequency of the breast cancer of left-handed women. What can you say about that? Well, I should say sorry. After the session, I should read more about this subject. I have never you heard, I thought that there is a joke, everybody who died ate cucumbers. I don't know, I never have heard about such statistics that left-handed women are more prone to breast cancer rather than right-handed women. Thank you very much. It's a very interesting thing to consider, but I would like now to give floor to a very famous specialist in oncology, Daniil Stroikanovsky. You know him all. He is head of the chemo department in the largest oncological clinic in Moscow. He probably will be talking more about the breast cancer, but I think talking about left-handed or right-handed patients, I don't think it's scientifically proved. Let's leave it to the end of the session, and if you have time, we might discuss it as well. So I think the speakers' reports today will give us answers to some questions. Okay, Daniil, the floor is yours. Thank you very much for the chance to talk to the audience today. I won't be talking about the treatment of breast cancer today. I will be talking about the screening of the breast cancer. And I would like to say that my report includes the data of Gilbert Welsh, a professor who changed my attitude to this problem in 2012 when for the first time, I read his works in the Medical Journal of Medicine, and then I went to San Antonio and heard his report in the preliminary session. So the higher is the stage of the disease, the higher the risk to die. So sometimes people die if the cancer detected at the late stage, and we believe if we can define them early, then we can treat or cure patients surgically. And there could be a methodology that can find us to detect disease at an early stage. Talking about cervical cancer, it's an absolute ideal place near to fire if you feel very comfortable. So, talking rhetorically, I don't want to speak a lot about it because with the cervical cancer everything is clear. But here we see 5 tumors that can be screened. And there is one more problem. It's thyroid cancer that also is a very relevant issue. Talking about breast cancer, and we believe that breast cancer is a disease that progresses with time and leads to higher mortality. And if you can diagnose this disease at an early stage, you can save the life of the patient. But then it turned out that it's a very complicated disease and tumors are very different. And not all of them can be detected at early stage. Not all of them can be cured even if they are detected at early stage. And not each breast cancer should be treated, should be cured. So screening could bear both benefits but risks as well. And today, by the results of clinical results, we don't have a big growth in saving life. We see that the biggest benefit is for women starting from 58 to 70 years old, and those who are younger than 40 years old don't benefit from it all. Talking about heterogeneity of the breast cancer, if we look at the total, it's that has invasive tumors that will never be life-threatening, and such tumors exist. If we talk about a bear, if there is a small tumor, it should be treated, otherwise it will kill the being. Or if we talk about birds, it should be a very aggressive type of cancer that most likely will be lethal. We don't know which type of cancer will be that bird, but we are trying to cover all the cases. And sometimes there is excessive treatment. Why does it happen? Because sometimes the disease may not be lethal, but if it's detected at a very early stage, then the patient is turned into an oncological patient. It could live 10 to 15 years thinking that she's absolutely healthy and thinking a very different, living a very different life. But at the same time, there are types of cancer that are lethal from the very beginning because they produce metastasis extremely fast. What two statements should be used in order to decrease mortality from cancer by screening? It should be focused on those type of cancers that lead to lethal to death. We should improve the diagnosis of late stages, and early treatment of cancer should be more efficient rather than treatment at the later stages. This should be an ideal program of screening of the breast screening. So we start screening, the early stage number goes up, the later stage number goes down. Within 30 years of onco screening and doing mammography, what do we have? The number of early stages increased dramatically among women older than 40 years old that underwent that screening. At the same time, the late stage amount stayed at the same level, which means that after the initial screening we have more patients, but as for the late stage, nothing has changed. What about women younger than 40 years old? This is a low curve. We see both early and late stage number stays at the same level. So 40 years level, it's an artificial level, and we have hyper-diagnosed forms. What does it mean? There is a disbalance that did not have not led to the decrease of later stage cancer, but it led to hyperdiagnostics of breast cancer. And it does not compensate by the deficit or decrease of late stage that have been diagnosed within this period. And Gilbert Wells, together with colleagues, calculated that during 30 years in the US, about 1.3 million women were hyperdiagnosed with the breast cancer within 30 years. If we look at the early stage, we see the following distribution. There is a high number of carcinoma in situ that does not, which almost never leads to death. But not carcinoma in situ was the only overdiagnosed disease, but all the invasive carcinomas that usually are not lethal as well. Talking about hyperdiagnostics of the early stage was due to the higher diagnostics of invasive carcinomas. What happens to the late stage? We see metastatic cancers, and we see that talking about the number of metastatic breast cancer, it stayed at the same level, and the patients with metastatic breast cancer would benefit the most if they would have made the screening on the right at the right time. So what did Americans get within the 30-year period in absolute numbers? So if you talk, we see that the incidence of early breast cancer went up dramatically, and the absolute change was 122 for 100,000 people. As for the localized disease, it went down by 8 only per 100,000 women. And as for metastasis, the picture has not changed. There is a good news that mortality from breast cancer has been going down steadily, but that is due to the proper treatment, better, more efficient treatment rather than screening. What can we say today? What are the conclusions that benefit from screening at the modern level is the breast cancer is a heterogenic disease, but we see that the benefit is not high enough. But hyperdiagnostics is a very relevant issue, and when we ask women, is it worth of doing it? We should not say that there is only one answer, yes, you must do it or you mustn't do it. It depends on the family history, at the density of the cancer, it depends on the fear of women to get the breast cancer, and so on. Thank you very much for your attention. Thank you, Daniil Georgievich. Does anybody has questions? Well, I have a question. Do you have other systematic trials, maybe that were conducted in other countries, not only in the US, or maybe multi-centered studies, that some results that you could share with us that have such convincing results? Well, actually, I didn't talk about just one trial because there were a number of trials devoted to the screening, not only the breast cancer, but the screening as a whole in the oncology. And they analyzed a big number of data by different nosologists, and there are different numbers. But we just now talk about the screening of breast cancer and changes that have been achieved in the US within the 30 years. Today, when we are in 2020, 40 years after screening was launched, and we understand that breast cancer is a very heterogeneous disease, and there is no one universal approach like mammography screening that can cover this disease for 100%. We are not talking about diagnostic mammography, we are talking about screenings or evaluations that is very important when some tumor, a small tumor or somebody is found. Okay? Is there any place in perspective for genetic screening? What do you think about genetic screening? Well, about 5 to 7% of women have a heritage risk of getting breast cancer. So most likely it's associated with a certain medical history. Sometimes we don't know about it, and we see sometimes very young women with breast cancer of certain type, or we can suspect that they might have problems. So in this cohort of patients, we have to focus on detecting breast cancer, but mammographic screening is not effective here. I think MRI of breast will give us much more precise result and could be more efficient and potentially can save life of those women. But I'm not talking about prophylaxis from a certain age in this regard. Daniil, you are so concise, it's amazing. Your answers are brilliant. Thank you very much. Okay, maybe why don't we make a Q&A session a bit later? I just want to give a very short comment. If we talk about, you asked a question regarding other publications. Hyperdiagnostics, if we talk about cancer screening, it's not only about breast cancer, it's more about prostate cancer, because in that field there is hyperdiagnostics. Hyperdiagnostics is huge, and I quite agree with our speaker, but also I would like to say that this is not the issue of the breast screening only, it's also the issue of prostate cancer. And a short conclusion, we actually do a huge damage to our healthcare system when we include screening of prostate. No other program includes this screening in other countries. At the same time, there is a novelty. Doctors today are paid if they made an early diagnosis. I think it's a catastrophe. It should not be done like this. Look, we will have epidemic of diagnosis, but not a pandemic of disease, like a pandemic of a certain disease. It's a very interesting subject to discussion. Let's just put it off to the end of our session. I also have a publication, a report on that includes Russian data regarding hyperdiagnostics, and I can share that results. There's the result of that publication with you. I have a question also. What is a certain damage of the hyperdiagnostics of the breast cancer? And you were saying that there is a small number of women that were not diagnosed with breast cancer at late stage. That is a small benefit of mammography. But if you compare damage and benefits, or harm and benefits, this is the question. Just to make patients to come and make mammography, are we talking about such kind of harm, or we are talking about prophylaxis prophylactic surgeries, and they get lymphedema, for example, and it's another kind of damage. But let's give floor to the next speaker. I would like to give floor to Linda Rebenik, who is director of Committee of the Screening of Colorectal Cancer by World Endoscopic Organization. The floor is yours.
Thank you very much, and it's a privilege to be asked to participate in this roundtable discussion. Maybe at the end we can have a comment about women at high risk of breast cancer. But we're going to talk about colorectal cancer screening and the question of whether it's worthwhile. So this slide shows colorectal cancer incidence in blue in men and women, and mortality in red in men and women in Canada over time. And we have among the highest burden of disease of any country. And I put the arrow there because there's a belief, a rule of thumb, that when the colorectal cancer incidence in men and women together gets up to 30 per 100,000, then a country should be screening for the disease. So we're very high. Incidence has plateaued, mortality has been decreasing. In the Russian Federation, however, both mortality for the disease in men and women and incidence, number of new cases in men and women, is increasing. Hasn't reached 30 per 100,000, but you can see where it's going. So there's a tremendous increase in the burden of disease in Russia, which calls our attention to what a public health issue it is in this country. This slide shows the lining of the colon, the normal on the left, and you can see the polyp that grows, a benign, non-cancerous polyp that grows over time and then sometimes develops into a cancer, which is the red part. Now, if you do a colonoscopy, it's not perfect, but you can detect these polyps and you can detect cancer. If you do a guaiac FOBT, you don't detect the polyps, you only detect some cancers if they're bleeding. If you do a fecal immunochemical test, it's a better test. You can detect the cancers and some, not all, of the polyps. And this is why the world has moved away from the GFOBT and now towards the FIT, or the fecal immunochemical test, for a non-invasive way of screening large population, large number of people for colorectal cancer. So in most countries now, people at average risk, 50 to 74, no symptoms, feeling fine, have the FIT, fecal immunochemical test, every 2 years. You do it at home every 2 years, and then if it's positive, then the recommendation is that you have a colonoscopy. So this is one example. There are several manufacturers, but this is one example of the fecal immunochemical test. It's just a single stool sample, no special diet. You don't have to be off your medications, and you put the cap back in the little tube and mail it off or drop it off at the lab. It's a very appealing test because in the laboratory, these are read automatically in a machine. They can quantitate the amount of blood that's in the stool. And so if you're running a program, you can have it a low threshold, so it's very sensitive, or you can put the threshold very high and have it less sensitive, and you can change that depending on what your colonoscopy capacity is. So you can change the threshold of the test if you want 10% positivity, or if you don't have enough colonoscopy for that, if you're screening a huge population, you can change the threshold of a positive test so that you only have 2% positivity or 3% positivity, in which case you need far less colonoscopy. So it's very compelling for a program so that you can tailor the cutoff to how much colonoscopy you have available. This is for people who argue that we should have colonoscopy for screening. This slide is to explain why not. So if you look at the row that says colonoscopies, let's suppose you do 100,000 colonoscopies in the middle column. 100,000 colonoscopies in people at average risk. How many cancers will you find? About 400. And how many of these precancerous polyps? About 10,000. You've screened 100,000 people. On the other hand, if you save the colonoscopy and use it for the FIT positives, if you do 100,000 colonoscopies in FIT positives, you'll detect 8,000 cancers, not 400, and you'll detect 45,000 high-risk polyps or advanced adenomas. And you can see that with FIT screening, you've screened 1.8 million people. So that the use of the fecal immunochemical test is a preferred test for colorectal screening if you're trying to screen a whole population. Yeah? So how are we doing? An example from Ontario, where I work. Canada's a large country, not quite as big as this country, but it's pretty big, but a very small population, 37 million. And the province where I work, Ontario, is the largest one, has 14 million people. So we launched our colon cancer screening program in 2008. This is the former Minister of Health. And I show you this slide because anytime you do screening, you need good support from Ministry of Health or Department of Health or people in government, because you need public funding to support them because these are large programs. So there's our former Minister of Health making the public press conference in 2008. So our program, when we launched it, was the GFOBT for people at average risk. But if you had a family history of the disease, a parent or a brother or sister, then you would go right to colonoscopy and not do the stool test. So we have average risk screening with the stool test, and people at increased risk have colonoscopy. That's our program. And if you have a screening program, you need a very good information technology, IT, or information system, and this was a big investment. And so we have all of the results from the tests, the stool tests, the colonoscopy results, all the hospital records, the cancer registry for the province, all goes into that IT system, and that allows us to send the letters of invitation to the people in the target age group and allows us to do the analyses and evaluate the program. And all organized screening programs, whether it's breast or cervix or colon, will have an IT system. You need to have an IT system to make the whole thing pull together. So we have reports on our performance. We put out reports. And so this is just one example. Here is the number in the screen-eligible target population. So you can see when we launched in 2008, there were about 3.5 million people, 50 to 74, which is quite a large number, and now we're way over 4.5 million, so that the challenge of screening the population increases. Every year goes up, every year goes up, every year goes up. And so how are we doing? Well, since we launched, This is the percentage of people overdue for screening. So we have screened more than 60% of people in the target age group, even though the number of people in the target age group is going up. Every year the denominator goes up. So this is an achievement. And this is to show you, this answers the question, for people with a positive stool test, how many go on and have a colonoscopy in 6 months? When we launched, it was only 62%. Very disappointing result, and you can see now we're up over 80%. A lot of work was done to get us there. People said, well, you're not doing a very good job, poor follow-up. And we said, yes, it's very disappointing, but at least we measured it and we know what it is, and now we've improved it. This is to show you the distribution of cases, so that let's just look on the left, stage 4, that's the gray. 20% of people, if you look at non-screen detected, 20% of people in the province with a new diagnosis, 20% stage 4. Over on the right, for those who had screen detected, 10% stage 4. So that's an achievement, a stage shift, and that's a good thing. And this was achieved only with the GFOBT screening. We're now using FIT, we've changed to the FIT, but this was GFOBT. All right, so what about the EU, where they have population-based screening? They put out this very nice report. It was a stock-taking report card on how they're doing. And you can see in Europe quite a variation in the EU countries in terms of some have the program rolled out, some are rolling it out, some are in planning, some are in pilot. A real mixture. But when they assessed the programs, they found some challenges. Population coverage, not complete. Participation rate, not what it needs to be. Not as good follow-up of people with a positive stool test as we would like. And issues with quality of colonoscopy. Tremendous challenges, even though the EU countries are moving forward in different ways, are moving forward with colorectal screening. So finally, what is all this doing? Well, I have 2 examples. This one is from Italy. This was FIT screening, and you can see in this region, Veneto in Italy, some regions launched FIT screening early, and some went later in time. And this slide shows you that in the darker line, those regions that launched early had a bigger drop in deaths, in colorectal cancer mortality, than the areas in this region that launched late. So early indication that screening is working, FIT screening is working in Italy. And this final example from the US, it's a very nice example where you can see the top line is uptake of screening, and the next line with the X's, they were doing colonoscopy and then they launched FIT, and you can see the big uptake in uptake with screening when they launched FIT in about 2006, 7, 8. And what happened? On the left panel, you see the colorectal cancer incidence went up. It peaked up when they launched the FIT, and then it's been falling dramatically. And on the right, deaths from colorectal cancer falling nicely. This is in California, Kaiser Permanente. Very nice example from the US. So 2 examples, one from Italy and one from the US, showing us that the launch of FIT-based screening is reducing deaths from the disease. So, in summary, we have much more work to do. I've shown you that our implementations are incomplete, but the early indications are that it's working and reducing the risk of death from the disease. So I would say that for sure, it's worth it. Спасибо.
Thank you very much, Linda. And 2 short questions to you. Yesterday, we had a colorectal cancer screening session, but be very brief.
Any other methods to screen for cancer, such as tumor markers or cancer cell markers, or was the project strictly limited to colonoscopy and the FIT test?
Yes, we would all like a better test than we have. The FIT is pretty good, but it's not perfect, nor is colonoscopy. But we have good evidence that they're effective, good evidence. We would like a blood test. One day we'll have a blood test. One day we'll have a blood test. There are some very promising panels of markers in stool. There are a number of them that they don't seem to do as well as colonoscopy. It's not clear that they're probably not much better than FIT, if they are at all, and they're more expensive. So for us, we've gone with the FIT. There's a lot of evidence to support the FIT. One day, we hope that there'll be a blood test for sure.
Thank you.
Спасибо большое.
Thank you very much.
Colorectal cancer mortality in Russia until 2010.
Yes.
Now rates of mortality are going down since 2010, and now colorectal cancer mortality is on decrease. Thank you.
Terrific.
That's it. I did not hear well the question. Well, we move on to discussions. In the end, we'll have the discussion, and I am very happy and grateful, and I would like to give floor to Daniil, the person who has the biggest experience of scientific studies of different screenings, director of the Scientific Institute of Cancerogenesis of Blachina Institute. No, thank you. For 10 years I was not the director. There were two directors of the institute which followed me, actually. I'm not the director of this institute anymore. And I like this name of our session. Yes, it's worth it, this oncoscreening, if the oncoscreening is in line with the standards which are proper. That's true about the screening. The screening which is based on scientific evidence, of course, it's worth and it should be implemented. I am unhappy that I don't have a presentation that I did several times at different events, conferences on hyperdiagnostics, overdiagnostics. And that report uses our incidence and mortality data from Russia, but what can we do? That's also important. And prevention of cervical cancer, lost opportunities and consequences for Russia. And we missed at least 10 hours, we're lagging behind. You know Professor Surhausen, who discovered the papillomavirus connection with cervical cancer and other cancers. I will speak only about cervical cancer today. You asked Professor about the time, how long it will take for fundamental studies, his fundamental study, to be implemented in clinical practice. And here it happened very quickly, and Professor Zurhausen received the first results in 1976. Then fundamental studies and lab tests and epidemiological studies were collected. And it was in the beginning of the year 2000 when the data was received, and the International Cancer Agency proved that the cancerogenity was proved of 13 types of viruses. Now it's 15 types of viruses. I will not list all of them. You see all of them in the red. These are HPVs, the numbers of HPV types. And I will not mention the types of cancers which are associated with these viruses. And I will continue talking about cervical cancer and prevention of cervical cancer. So there are factors. That's a virus, so it's a viral nature, and of course there was a need to take certain measures to prevent it, and prevention vaccines appeared So quadrivalent vaccines, I will not read out the names because that's about advertising and I don't have time anyway. And then these vaccines appeared in 2007 in Australia, Canada, by the way, and in some Scandinavian countries. The national programs on vaccination of teenage girls, were implemented to prevent the tumors associated with the HPV viruses. You have two studies. I'm sorry, I will not read their names. This is randomized clinical studies which prove the efficacy of quadrivalent vaccine and double-valent vaccines. They are very efficient, both of the vaccines, and the population of women was over 5,500. These were teenage girls, teenage women. They were split into two groups, infected with HPV and non-infected. In non-infected group, the efficacy was almost 100%, that of vaccine. There was no pre-cancer or change or cancer. In control group, the number of tumors was quite high. I think it was about 60. The efficacy of the vaccine in non-infected teenage girls was 100. And HPV infected, the efficacy was much lower, 55%, and that is clear. This is another study with a bigger population, but the results are in fact the same. And 100 efficacy and less efficacy by 50% among infected women. And the efficacy of those vaccines was proved. And many Western countries, developed countries, they were not sleeping in 2007. And the state program on HPV teenage vaccination was implemented in Australia. And I quote Australia because their program was a great success. And coverage is very important. And we spoke about screening about this. And for screening, coverage was important. In Australia, they covered 78% of girls who can be prone to vaccination at the age of 12 to 14. Then they started vaccination of boys. 73% of boys were vaccinated under this program. And also they followed up those teenagers after vaccination results after 10 years. I will not give you the details of these slides. So in this slide you can see the change in infection rate, and for both vaccinated and non-vaccinated women and population of Australia in general of this age group, HPV infected. Summarizing this slide, because of vaccination there was almost eradication of HPV 16, 18, 6 and 11 in women. These are the viruses including a quadri vaccine, and for women who were vaccinated at the age of 12-13, there was decrease of infectious rate of the same types of viruses in non-vaccinated women, and decrease of infection rate of other types of HPV in non-vaccinated women. So that was cross-immunity. And this is the practical data of usage. These are the outcomes, practical outcomes of this program. Here you may see data from the countries which were the first to launch such programs against HPV vaccination. It's Australia, Canada, Denmark, Sweden, and many other countries. And summarizing this slide, I can give you the results of a Scottish retrospective study. By 89% decreased the incidence of intraepithelial neoplasia of third stage and in situ cancer. The girls who were not vaccinated were compared against vaccinated girls. It is just the girls who were born earlier in 1988. They were not vaccinated at that time. The girls who were born a little bit later in 1996, 1995, they were vaccinated. And by 88% there was a decrease in incidence of SIN grade 2 and SIN grade 1 by 78%. So which is a very good result. And very quickly about screening. And this is mortality from cervical cancers in the countries where the screening was successful. What do I mean by saying successful? These were controlled protocols with quality control and with follow-up for the population, screened population. As you may see, in all of these countries, there is a decrease in mortality rates. And that's about Russia. In red, we see the numbers for Russia. Everything was quite good, you see. Before the beginning of the 90s, there was a decrease in mortality. After that, there was some growth. And other countries are there. So you see UK, France, Poland, Hungary. And in the beginning, our trend was like the trend in the UK and the US, but in the 1990s it all changed, and the explanation is quite simple. Before the 90s, we were somehow, I say somehow, because we never had populational screening, cytological screening, but examination was done for all young women. In fact, despite opportunistic screening that was not a targeted screening, its coverage was universal, and you see it was reflected in mortality rates. And then it was disappearing, it was eradicated, such screenings, the mortality rate increased. By the way, we have a checkup program introduced, but there are no changes in mortality rate. And I would like to compare two types of screening. And I started to speak about HPV infection. It accounts for most of cases of cervical cancer, 88%. And HPV titer screening, sensitivity 96%, it's very good. And specificity 91%. As cytological test has sensitivity which is quite low, and that's important because we can miss lots of tumors and lots of cases of HPV and potential cancers. That's important. This is not my information. That's not my data. Now, comparison between HPV test and cytology. Just have a look at these numbers under HPV and cytology column. Look at those columns. In all of the studies here, this is European randomized studies. The sensitivity of HPV test is much higher compared to cytology, and that's very important. That's an important slide indeed. HPV negative women. It turned out they are negative for HPV. They can live at least 7-8 hours because the risk of precancer pathology or cancer remains very low. It speaks about the following fact, and at the bottom curve is cytology, and the red curve HPV, and green is cytology plus HPV. Of course, it's preferable to use the test. And the conclusions. Based on scientific data, we can say that primary screening should be done in form of HPV test with cytology, and for HPV positive women, we decrease the number of cytologists, and especially in our country, we do not have enough cytologists, enough lab assistants to perform such tests. We don't have people to do those swabs. And then the sensitivity is superior to cytology, I mean HPV. And HPV negative women have a low risk to develop cervical cancer for at least 7-8 years, which also increases the screening interval up to 10 years. This is a Director General of WHO who recommends us to launch HPV vaccination and use HPV test for screening. And that's adequate for our country because we have issues with cytology workers. Do I have 1 more minute or not? Of course, you may have 1 more minute. So these are European registers, 3-4 registers with the highest incidence of cervical cancer. So the first is Karelia, Samara, and in our country, I'm not comparing our country with some faraway countries, and we are a European country, and we should be compared against European countries. I insist that Russia is a developed country and European one. What happens with cervical cancer? This is incidence rate. I showed you mortality. And the incidence is worse, even worse than mortality. The mortality is stable, and this is the forecast. And by age group, with a split by age groups, you see the red line, and the incidence will be increasing according to all information. This is Australian data. They forecast. They make a forecast. They have both vaccination screening, and they forecast to have by 2030 4 cases of cervical cancer per 100,000 women. After that, 1 case, and cervical cancer becomes a rare disease. But in our country, by 2030, we will have a different story. 30 cases of cervical cancer per 100,000 of population, and you can make your conclusions yourself. And the chart in Australia is to the left. It will go down to such a level that will become a rare disease, I mean cervical cancer. And what is happening in Russia? You have seen it. Thank you for your attention. Thank you, David. That was very convincing information. It's not the first time that I see this data. And for now, we don't have obligatory this vaccination, and the vaccines are accessible in clinics, outpatient clinics. I hope that we will further promote it, and we will promote it, and we will use the best vaccines. I would like to say that we have time. All of the agenda was delayed of the whole of our assembly. We should not just finish on time. We are not obliged to it. Then we have the lunch break. And I hope that we will have discussion now. And now the question to David. Aykov Ilya, Head of Foundation for Development of Social Programs. Our foundation is implemented executing programs of cervical cancer screening in December 2019. We finished, together with the Healthcare Ministry of Bashkiria Republic, a pilot project on screening of cervical cancer using a WHO protocol that you mentioned. We tested 30,000 women of the relevant age group, corresponding 10.5% HPV positive high risk, and finally we had 300 patients, and 19 of them had stages 0 and 1, and the rest were scene 2 and scene 3 dysplasia, and there was another developed for further treatment of the patients. And my comment is the following: if we take our order on checkup 214N, there is a cytology but no HPV test, unlike profiled specialized decree on gynecology and obstetrics. And we were talking about the government of the Russian Federation Healthcare Ministry. Well, based on that, we need to include that into the guarantees provided by the state. What's the question? The question to David, what is, how can we prove that we need HPV testing into regular checkup? I don't know. I know that it must be done. I don't know how to achieve that. I do everything that I can. I am speaking a lot, and you heard my presentation many times in many places. We have a big conference. We had a big conference recently, and you attended this conference, but I don't know. I don't know how to make the government include that. And let us move on. And we are a partner of HPV Society, and I'm so sorry, let us stick to our agenda. And we are for cooperation, we are in favor. Please come, we can hold a separate discussion. Accessibility of vaccine is very good in Moscow, and the question of massive vaccination, that's the second question. We need to work on that, and they hear it, and David is playing a major role here. And we work together because there are some priorities in cancer service of the city, and we are solving many problems. Those who are present here, they can confirm that. And they all were involved in improvement the quality of oncological service. And it's all about these questions, and these were not first priority provision with treatment, with medication and drugs. That was the major priority. We started to do that, we started to deal with that. It will happen in the future, I have no doubts. I would like to give floor to head of optimization of different methods of treatment from the center named after Rogachev, Mr. Zhukov, Nikolai Zhukov, and he will make a summary lecture on screen, and then we will have time for questions for the discussion as well.
Hello, dear ladies and gentlemen. Please switch on my slides. In fact, first of all, I would like to say that when I found out that I was going to take part in one session together with Nobel Prize Award, I was trying to do this lecture as simple as possible. But there was another reason, as Igor said. I was told to do I was asked to do some conclusion lecture, but if I was talking at the position of a doctor of science, I think it is very important being in this panel with people who have different opinions. I can't be above of this discussion, and because it would be, yes, otherwise I would have to represent another opinion. Sometimes we have to make a step aside and look at the system from another perspective. What do I do in my routine clinical practice when I have a difficult situation to solve, or, for example, parents or relatives are not ready to make a decision? What do? I'm trying to put myself in the position of the patient and decide what I would prefer in that situation. As for the screening, it's even easier for me. 4 years ago, the state gave me my last passport when I turned 45 years old. So I am eligible for the screening of prostate cancer and colorectal cancer screening. And as I smoke, I will be eligible for lung screening as well. So I have to think about it and verbalize what I feel when I talk about the screening. So let's talk in the human language, in the language of human beings. What do we think when we talk about the screening, and what issues may arise if we are in the position of the patients? So screening, it's early diagnostics to reduce dose. There are false positive results, hyperdiagnostics, and so on. But talking about oncological screening, and this is a very precise number of measures that really can prove the mortality rate due to detecting cancer at the earliest stage of a certain disease. Why? When I was writing this slide, I wrote that we are talking about trying to find a decision at a very difficult situation. Well, I would agree that screening and oncological screening really save lives, but there is a big but. It's not shouldn't be done to all patients at all times. Unfortunately, today there are no ideal options for oncological screening because we evaluate hundreds of thousands of people who go through some uncomfortable conditions in order to help dozens or hundreds of people. So KPI of this procedure is very low, as we understand. You could say, and you could be very right, that this is a core of prophylaxis. So we have to evaluate hundreds of thousands of healthy people in order to save lives of dozens or hundreds of people. But if we look what goes next after the vaccination, you can understand that talking about consequences, for example, of the vaccination, had consequences, the rate is very low. First, you will take a blood test, but the mistake in a screening test, you will go to this, you will get into the chair and you will get lots of other tests. So as a screened person, I should understand that there should be a very appealing task for me in order to be involved. So talking about pseudo screening, some active early diagnostics, in other words, some evaluations that have some rationale but do not have any proof of influencing on the mortality rate. I am not ready to go through some uncomfortable measures in order to understand my diagnosis early without changing my destiny and future. Because if we look at this procedure from the eye of the patient, you come to some checkup and ask, doctor, due to your test, due to your test results, do I have a chance to live longer? I'm not sure, doctor says. Maybe we will find the tumor at an early age, we will start to treat it early, and then I will be able to report about my active approach. You can ask, you can tell me that I'm being unfair, but here there are some statistics on the Russian Federation. You see the second column shows that in different regions of Russia, for example, for the breast cancer, the number of detected cases in different regions varies, but as for the 5-year surveillance and 1-year mortality, the numbers are quite the same. For example, if we talk about stomach cancer in Moscow and Moscow region and Kostomy region, the detection differs by 3 times, but mortality rate is quite the same. So that means that any checkups like colorectal checkup and so on do not look active to me. So what shall we discuss if you want to change the mortality rate? But there are only 5 tests: cervical screening, colorectal screening, and so on. Why? If we look at the situation from the perspective of a patient, why this golden brick doesn't overweight the disadvantages? What are the disadvantages of the screening? What is false positive result? In other words, when a tumor is found or screening has worked out when there is no tumor. From the point of view of the doctor, it's not a big deal. Okay, patient get nervous, so on. Not a big deal if you want to save lives. But what goes next after the false positive results? Well, we talk about the situations when the doctors will, put lots of needles into you, will do lots of other tests, and then who will benefit? Nobody will benefit, not you at least. In terms of the responsible patient who independently found some negative symptoms or malign symptoms, what it could lead? It could lead to hyperdiagnostics. There is an overburden on the healthcare system, and if I am a responsible patient with a lack of resource, I will waste lots of time trying to define my health status. In many situations, symptoms appear at a very early stage. Plus, we remember that not for each types of cancer there is a screening, and the system of onco-evaluation is the same. And there are interval cancers where they appear between the screenings. I can't say a good word about evaluation medical checkup program. There are questionnaires that have to be filled out by the patient, but at least this program allows to detect symptoms among the patients that sometimes general practitioners cannot define due to the lack of time. And this is a problem of our country. We do not give very precise guidelines to the general practitioners. We can describe systems, but if our general practitioners have only 12 minutes for each patient, they simply have no time to listen attentively to each patient, and therefore they just neglect some symptoms. Talking about negative false result, it could lead to lawsuits, and it's anti-advertisement of screening measures, because those who did screening but a tumor was not found feel very depressed. And again, the feeling of protection, it's a false feeling, because if in parallel there is no campaign that explains people that there are symptoms, we have to be aware of them and track them if they appear. So people who go through screening and think that everything is fine, they have a false protective feeling. As an educated patient, I do all the symptoms, but what about our general patients that go through the screening problem? Do they know what the screening is about? Next topic is hyperdiagnostics. How does it look from the side of a patient? First of all, my prostate, my lung, my intestine, and my breast, they are very dear to me, so I would not want to depart from if there are no any reasons. So what is hyperdiagnostics of prostate? I felt okay, went through the screening. I was found a tumor that was treated surgically. I got some medical issues, and 20 years later I died of the heart attack, the same time as I would have died if my prostate cancer hadn't been treated, but I'm talking in general, of course. Therefore, talking about the screening for others, we should remember what the patient feels about the screening, and it's not very difficult. And when I hope that I would like to tell the most important thing. In fact, I'm talking about I would like to say something positive about screening, because it really helps to save people's life. Maybe they have to undergo some uncomfortable things, but it helps to save people's lives. But the decisions made should be made on the basis of rationale. So me as a specialist, I made the following conclusions. So how I would solve the problem with the screening regarding colonoscopy and test, yes. For me, yes, the benefits are more important than some uncomfortable procedure. As for antigen, for me, yes, because my father had prostate cancer, so in my medical history there is a high risk to have it. It's 40 times higher than compared to other people. As for the CT of the thorax, yes, I smoke. I'm addicted. I do not smoke now, but I used to smoke a lot. So I don't know what's going on with my lungs when I turn 50 years old. And so I have to take a decision myself whether I want to do lung screening or not. As for my spouse, yes, and if you talk about mammography, yes, she, I think, should do mammography. But at the same time, I would not say I support this screening for 100%, because I do understand that there are disadvantages and advantages, and they are at the same level. And the question how we should raise awareness among our patients. Well, certainly we should raise awareness and educate our patients, but at least they should come to our clinics and get that information, and a certified or qualified person should talk to them, and such a specialist simply need time to talk to each patient. Do I have 3 or 4 minutes? Okay. I will then cover one more issue. So why did I make such a structure for my lecture? Well, looking at what's going on this conference, if we decide that screening or early diagnostics based on the awareness of populations and their knowledge of symptoms should work, what shall we do? 10 mammographs? How many? 100, 500 tomographers should be bought? No. First of all, we need people to come and be evaluated. So how can we motivate people to do screening, so to come at a clinic at least? We should motivate, we should make you interested. And there are people who know, specialists who know how to do it. We are talking about PR. Those, they are not doctors. We should not expect that doctors will push people to undergo screenings. How does it work? So some people suspect that they have a bad odor from the mouth. So who wants to get rid of it? Everybody. Well, advertisement works very well, and we all want to get rid of it. So that's how you can actually influence people's mind. Most of the people do not have motivation to increase risk of cancer or risk of mortality or later diagnostics, but the PR can change this attitude. If you don't believe so, ask yourselves how many times have you thought about doing a screening, or how many times do you think that you could die of cancer? Well, the answer would be next to 0. But when we do an effective campaign, we make people to think about such issues more frequently. It's a great board that I saw in Singapore, Lift Your Skirt, Save Your Life. It was made by a very good copywriter, a very good PR agency. So this is a call to do cervix cancer. How does it look in Russia? You can Google it, screening of the cervical cancer, and you see very bleak billboards that do not appeal people's attention. The only one I liked was with the cat. So any women who will see this cat, who will go to screening? The question is where to put this billboard. Well, I was at the clinic where Daniel works, and they have billboards about necessity to do early diagnostics, but why are these billboards in the clinics? Such billboards should be outdoors. They should be placed there where people live. And I was very pleased to see the creative approach used by the health department of Moscow. I would, could argue about the contents, but regarding, the motto, the slogan, it was splendid, it was great. It means that we are moving in the right direction, at least start to do it. Going back to colonoscopy, here you can see a video of the first colonoscopy made by Will Smith. You know this actor, of course. He is a genius, and he told what happened to him. And look how many people watched his video. Almost 3 million people. So if you could make similar videos, so if you could make great billboards, we could get better results. So how does it work? The most efficient thing to do, just one more second, is how can we make people quit smoking? 5 years ago, I quit smoking myself because I felt very uncomfortable. But due to the anti-smoke campaign that started in Russia, we can do a lot when we want. We should know what we want. Yes, thank you very much. Well, thank you very much, Nikolai. Fortunately, we ran out of time. I hoped we would have time for discussion, but unfortunately we can't make it because therefore we have to stop our discussion. At the end, I would like to address the audience. After such skeptical comments you heard today about the screenings. Thank you for listening to us, and thank you for understanding that we have to, that you still understand. So raise green flags if you believe that screening is necessary, just after hearing so many negative things about the about the screening. And now raise your hands if you think that screening is not a thing we should do. Okay, just one flag is raised. A very difficult problem, a big issue, but talking about colorectal cancer, then it's one thing, but hyperdiagnostics and hypertreatment depends a lot on how smart is the potential and how smart is the patient and how smart is the doctor. Thank you very much for participating here. I would have raised, yes, a red flag as well, or the green flag as well. So, okay, thank you.